This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we are going to be discussing a paper comparing methadone to buprenorphine. How are you today, Sonya?
Doing really well tonight. How are you doing, John?
It's good. I think we talked earlier, we normally record on Thursday. I have a low emotional energy level by Thursday night. And so doing a Monday night, I feel like I'm fresh-eyed for the week here.
Right. The week is young. You have the whole week spread out in front of you to do good, treat addictions, see patients.
Yeah. How about you? Anything exciting going on?
Nope. Just a lot of stuff with family, work. It's a good week here in December. I don't know when it'll be when this finally airs, but it's a, beautiful day today in Adams County, Pennsylvania.
Okay. Yeah. So anything exciting going on in addiction news that you've been reading about?
Yeah, there was a guideline from ASAM I wanted to share with people. I was really interested in it. It was titled Engagement and Retention of Non-Abstinent Patients in Substance Use Treatment. At this point in addiction treatment, the concept of dismissing a patient from treatment if they relapse on drugs is kind of on the outs in the addiction medicine community. But I do know when I started treating patients, which was more than 10 years ago, we had a little bit of a abstinence-only treatment program. Like, if you tested positive for other drugs or any drugs, you got, like, a few chances, and then you were dismissed from treatment. We kind of demanded abstinence from drugs from people, when I was working with another organization. But, the broader treatment community really has had to grapple with how that did not work and how to work with patients who seek out treatment but continue to use drugs. Even those who want to continue to use drugs compared to people who don't want to continue but have trouble stopping. There are a lot of people who want to use drugs at a lower, safer level, but don't really have total abstinence as their primary goal. They might have a drug of choice they want to stop, like, opioids, fentanyl, but they have no problem with using cocaine or alcohol, and they would like to continue to use that recreationally. So how do we work with people in that situation as opposed to people who just want abstinence? So ASAM put out a guideline about this, and they included 10 recommendations. I'll link to the full document in the show notes, but in general, they recommended a bunch of things. They recommend making treatment supportive and welcoming, of course, non-judgmental, eliminating any punitive aspects of treatment. And I've worked really hard to do that. And I tell people right out, like, I'm not going to punish you. I'll recommend what I think is best. I'll give you the treatment, but I'm never going to punish you for relapsing or using drugs. They said the clinic should emphasize retention and engagement as primary desired outcome rather than drug abstinence. And we see that in research. Some of our research looks at abstinence as a primary outcome. Others look at duration and retention and treatment. They also recommended only dismissing patients from care as a last resort and not because of drug use itself. And finally, they included prioritizing retention of frontline staff, which I thought was interesting. A quote I wanted to read is, quote, treatment program staff commonly have lived experience with substance use disorder. Programs should be aware that their staff may struggle with mental health concerns and be susceptible to vicarious trauma. Efforts to build and retain skilled staff should acknowledge that many members of the substance use disorder workforce have experienced trauma and may continue to be exposed to trauma as part of the work that they do. And I just really was interested that they included that support of frontline staff in the recommendations for engaging and treating people who are not abstinent from drugs. So, John, what do you think of that concept?
I think you're right. It's way different than, not that you've been doing this a little longer than me. In fact, like, I think when I first started, when I first started, you were the ones that kind of gave me some of my on-the-job training. But you're right, especially early on, I feel like there was a more of an abstinence-only approach. I remember being like the fringe guy early on because, like, if someone had medical marijuana, I was fine with seeing them. And, like, that was like a big thing in the area. Like, oh, I'll see the medical marijuana patients too.
Ooh, yeah.
And I was like a rebel at the time. Now it's like, I think that's pretty much everyone's let that go.
Right.
Yeah, they're interesting concepts. It is hard. I think like Mitch Crawford, who's like our director of addiction services, he's really cool. And one thing he said one time was look at like your different silos, right? And like, you might have opioids as one silo, alcohol as another, but like you shouldn't kind of judge success in one area based upon kind of an abnormal or unexpected result in another. And really, it just needs a second treatment plan. Um, Now it's just harder because a lot of those other substances don't have like a smoking gun treatment like buprenorphine or methadone, right?
Right. I mean, I think of all the different drug uses as distinct, but also not distinct. I think of it as, think of the metabolic diseases we deal with: diabetes, hypertension, hyperlipidemia, coronary artery disease, obesity. Those all kind of come together, and the single sort of lifestyle treatments often treat them, and often medications for one treat one of the others as well. So they're not totally distinct, and yet they are more or less distinct. Diabetes is one thing, hypertension is one thing, hyperlipidemia is one thing. You treat them separately with separate drugs, and if you do poorly with treatment of one, it doesn't mean you're going to do poorly with the others. And I think of drugs kind of the same way. Um, they're different and they have different treatments, but they do kind of come together. The same forces that push you to use stimulants might push you to use opioids, and vice versa.
Yeah, it's interesting about the frontline staff workers. I remember when I really kind of first started like ramping up the addiction part of my practice. I have I'm keeping it honest. I have a staff member that I work very closely with that spends a lot of time working with me, and they did not kind of enjoy working with me during that clinic. It wasn't until like some time later then they were like that one time they wouldn't kind of spend time with me or wouldn't work with me, that it was kind of like they let me know that this was a very kind of like triggering and kind of close to home phenomenon for them. And so like, I didn't know that. And I didn't even think that that would be something to kind of explore beforehand, but it was kind of a painful thing for them. And actually they've kind of over the years, now they actually spend a lot of time with me in that clinic. It seems like it's come full circle, and I think they tend to enjoy it for the most part, although we do have some difficult situations. But I think, it's like the airplane, right? Sometimes you got to check your own oxygen mask before you put the oxygen mask on the person next to you.
Right. Well, and I agree that, you do have to support your staff, and sometimes you have to support your staff at the expense of supporting your patients, because if you lose qualified staff, then you can't care for anybody.
I feel like we're often kind of blind for this too. Like I feel like the two places I'm blind, like if I'm in the room with a patient, I can kind of pick up subtly that something's wrong. I can pick up the way they're talking about something, that they're not saying something, and you can kind of explore that. I'll tell you, sometimes with my staff and then at home with my with my wife, sometimes I just totally miss the boat that something's going on. I don't know why. It's more of a comfort zone there, but I'm like, how did I miss that one?
Right. Oh my gosh. Don't we won't tell your wife you said that. Does she listen to the podcast?
I think sometimes. She's like super mom on the PTA, and she's doing everything and running around like a madman. So I don't even know how much time she has to like sleep.
Right. Oh my gosh. Yeah, I mean, I feel that way too. I sometimes just, we're working in such a busy environment. You forget to take a deep breath and make sure everybody around you is feeling okay as well. And I think the reason that this is, I mean, I don't know exactly why they included that recommendation in their guidelines, but I really do feel like sometimes, our staff who are in recovery themselves, they're not actively using. It's a pretty intense workplace, and if you're actively using a lot of drugs, you can't really function in it. And so having to be in contact with a lot of people who are also actively using, I think can be difficult. They're happy to be in contact with people who are doing well, but people who are doing poorly, like the guidelines say, can be kind of triggering and difficult for some people.
And there's secondary gain in some regard where like, I think people will kind of use the staff sometimes more as a punching bag than they will like me or you, because we're writing their script for whatever they would like. So I think that they know in the back of their head that some of that behavior they're gonna spare me from. And I feel that the staff, especially like my recovery support people, sometimes I think they get it way harder than me on some of these tough situations.
Well, right. They take some abuse from patients, but also they become, I don't want to say emotional, like receptacles for like emotional dumps, but I think patients also sometimes feel they connect with them a lot better than with me. And so they share a lot and a lot of traumatic experiences that can be hard to hear, for anybody. And then the staff have to hear that and they have to process it themselves as well. So, how about you, John? Anything in addiction news you want to share with our audience?
Yeah, this is kind of always an interesting concept. This is from Stat News, and the article's titled "The Recovery Community Says It Offers Refuge from Opioid Addiction, but It's Still Hostile to Life-Saving Addiction Medications." And this article covers a theme that I see like all the time. This kind of patient with opioid use disorder named Mark Polinsky is talking about how he was actually asked to like leave an NA room because he talked to during the discussion about someone else should consider medication to help their disease. Um, and it's interesting that this is really an area of quite a bit of dissent in the recovery community. Like AA and NA do not mix, right? So AA does not want to hear about NA, and so if you have a narcotics issue and you go into AA, you have to call it like I'm shooting up alcohol or something. Like you have to make it sound like it's alcohol. So for some reason we're hating on people with other issues, and then the
Mhm.
idea that like I got better this way, this is the only way. And I hear this all the time. I got like a spectrum of people in my office. I have a lot of younger patients that, a lot of them do use kind of medication adjuncts for their recovery. And they have a bunch of those kind of like old, like Sterling guys that are like 68 in recovery for like 30 years. When, they talk about the meetings that they went to. And I see them in my general practice, most of them. Um, and they're like, well, I didn't need any of these medications in my day. I'm like, and the one time I was like, like probably like twice as many of your friends would still be here if you had those medications, right? Like, I'm glad that this worked for you, but like, how many friends did you lose along the way
Mhm.
to get here, right? So I don't know. It's again back to this one size doesn't fit all. And it's interesting for recovery, for a community you think that would really band together. There really is still a lot of stigma for medications among people in recovery. So like, it's just I don't get it. I've never understood this.
Yeah, I don't know either. I usually just tell people, "Hey, like, if you were taking the drugs that are available now instead of the drugs that were available in the '70s, you'd probably need medication too," you know? It's a different world out there. And I think that's what opened up a lot of the recovery centers and recovery, like rehabs and detoxes to medication. There was a whole rash. It was a few years when all these people were overdosing and dying the day after they got released from inpatient rehab. And all these rehabs really started to reevaluate their non-medication based programs. Um, and now anybody who wants to can get started on medication and rehab and be discharged on that medication.
Yeah.
Yeah, but I can't answer why people feel like it's, cheating, quote unquote. I mean, it's not the American ideal is like medication for everything, right?
I feel like doesn't it just seems like everything, like, it was harder for me, it needs to be hard for you too, right? I think this is like an American, like, made in America concept, whether it's, not to get political, student loans or recovery or, you know,
Doctors, medical school.
the
I got
medical
abused in
school.
residency, so should you now.
These new residents are so soft. I hear that all the time from the old people. I'm like, I don't know, they seem a little more emotionally adjusted than some of us. What marriage are you in?
Well, it's true. I look back on some of the more difficult parts of my residency, and previously I might have like bragged with pride about how hard it was, and now I just feel like it was kinda sad that I had to do that.
Yeah,
The stories ring kinda hollow when people look at you with horror. They're like, "You did that? Oh god."
yeah.
Oh, well, shall I get started on our article?
Yeah, let's do it.
So, this is a really cool article, and it generated a lot of conversation. The title is Buprenorphine Naloxone versus Methadone for the Treatment of Opioid Use Disorder, published in JAMA October 2024. Um, Published online in JAMA October 2024. So, I'm really excited to talk about this paper because methadone and buprenorphine are the two best treatments for opioid use disorder, and it's really great to see them studied head to head. There's been limited comparative effectiveness research comparing these two medications, and previous data on methadone did not include patients who were using fentanyl and on many subgroups. So, a study comparing the two medications, methadone and buprenorphine, is really needed, and I'm glad we get to talk about it. In general, John, methadone promotes better retention in opiate agonist treatment. Um, and that's seen in systematic reviews of over 1 million patients. So people stay in methadone treatment longer than they do in buprenorphine treatment overall. But in the US, as you know, methadone has these very strict regulations that make methadone treatment very burdensome, complicated, and inconvenient for patients. This includes things like daily dosing and only being able to dispense it in certain clinics. With the increasing ease of use of buprenorphine in the US, which can now be prescribed by any doctor with a DEA license and picked up at any pharmacy, buprenorphine has really become the preferred treatment for many patients for opioid use disorder, just because it's so much easier to access. This study, though, was done in Canada, and both methadone and buprenorphine naloxone are available in office based settings, and it's much more easy to make the comparison. So in Canada, methadone and buprenorphine both can be prescribed in an office-based or an addiction specialty treatment center. It can be dispensed at a pharmacy. You don't have to only get it at the addiction clinic. And methadone, you can get up to 2 weeks of take-home doses, and that's allowed after 3 months of stability. So this is a little more relaxed than in the US. So after you're stable for 3 months, you can take home up to 2 weeks at a time of your methadone that you get from the pharmacy. Buprenorphine naloxone in Canada is more restrictive than in the US, so you can get up to 2 weeks of take homes almost immediately. Whereas in the US here, it's prescribed like a controlled substance, but you can give multiple refills on a prescription. I think theoretically, you can give up to 6 months worth of refills and not have to see a patient again. So they're a little more restrictive with buprenorphine. So before we launch into this paper, John, do you recommend methadone for patients with opioid use disorder? Um, and when would you send a patient to a methadone program? When would you recommend methadone compared to buprenorphine?
I think it's tough because I think most of the people, except when I do like inpatient evaluations, they're already coming to me for buprenorphine, right? Often I'll even kind of talk about other options. They don't want to hear it. They kind of know what they want when they come in. So I think that when I talk about methadone, it's often when kind of people are struggling in the buprenorphine program. I'll be honest with you, with the newer formulations that are available between kind of like, the sublingual, but now these kind of depot formulations, I find myself having that conversation for someone like, I hate the word failing treatment, but needing a higher level of treatment or a higher level of medication. I find that less common.
Mhm.
And this topic of one outside the other, I often find it's tough because you're right. It's really hard to put these head to head because, like, you're looking at the medication, but at least in the United States, kind of like an OTP experience is very different than kind of how most patients receive buprenorphine, right? So I feel like the X factor for me in this question has always been like, what's the effect of just that rigid OTP in outcome versus, the medication? Like, what's doing what there?
Right. Well, right. And I think a lot of my patients view methadone more as a last resort, so they'll do buprenorphine first, and if they fail, they'll do methadone. But it's not because methadone is bad. A lot of my patients have told me they would prefer methadone. It feels better, but the methadone clinic setting is so restrictive, and it's not even available everywhere. Like at my second clinic in our more rural county, there is no methadone clinic. The closest one is maybe an hour drive away. And one of them is across state lines in Maryland, which then you run into insurance issues with. So, it's just not available for people. So eh, it becomes a treatment used for people who are truly desperate, but not because the treatment is bad. It's just because the setting makes it so difficult. You really have to want it to be successful with methadone in a lot of our areas.
Mm-hmm.
So yeah, and I'm the same. I'm treating people with buprenorphine, so people don't come to me looking for methadone. But maybe in the future, I'd like to be able to prescribe methadone for opioid use disorder. So let's talk about this clinical question. This was a population based retrospective cohort study. So it looked at charts retrospectively. They compared patients on methadone and patients on buprenorphine naloxone, and the primary outcome was treatment discontinuation and mortality. This study included people who were age 18 and over, had a diagnosis of opioid dependence, and no prior attempt at opioid agonist therapy in the past 14 years, which was how much data they had. So people who were starting treatment for the first time for opioid use disorder, that was the main group. We called them the incident users. They did a secondary group of prevalent new users who were starting opioid agonist treatment, and they hadn't done it in the last 30 days. So they may have been on treatment in the past, but they weren't on treatment actively at the beginning of this study. They excluded people who were incarcerated, pregnant, or receiving palliative care. In terms of who ended up in this study, it took place in British Columbia, Canada, like I said before, between 2010 and 2020. They stopped collecting data March 18, 2020, which was when the COVID-19 health emergency was declared, which I guess is a good stop date for data collection. 66% were male with a mean age of 33, so relatively young. About 40% were receiving income assistance, and about 8% had unstable housing in the past year. About 7% incarcerated within the past year. So a population with a certain number of challenges. Most of them were treated at large addiction clinics rather than primary care offices. And they were a relatively young and healthy population, very few medical or mental health comorbidities. The thing we're looking at is buprenorphine, naloxone, which was about 40% of patients getting the first prescription since 1996. Um, and we compared it to getting methadone, which was 61% of patients' first prescription, again, since 1996. Outcome was treatment discontinuation, and the secondary outcome was all-cause mortality, and the time was 24 months. So they followed patients for 2 years or until the end of the study, whichever came first. So basically, again, population-based retrospective cohort study comparing patients on methadone to buprenorphine, naloxone, and saw who stayed in treatment longer and what was the mortality of the two groups. So, John, what did you think of the clinical question?
I mean, it seems very relevant, right? Kind of mortality is a great primary outcome. Seems like a very similar practice setting, kind of putting the kind of medications head to head, which is like the real question here.
Yeah, I agree. It's a good question. And I thought the trial was valid. It had large size, 30,891 patients, ending up with about 25,000 in the per protocol analysis. So a really big study. Like you said, the Canadian setting allowed for more valid head-to-head comparisons between the two medications. They did try to control for potential confounders, and they pre-selected them, things like age, sex, urban or rural, living situation, poverty, housing, incarceration, mental and physical health issues, a whole bunch of things, a big list of confounders that they control for. They did a per protocol analysis, and they did multiple sensitivity analyses to see if their findings would hold up in, a bunch of different situations. And I thought funding was unlikely to cause bias. It was funded by the NIH and NIDA and the Health Canada Substance Use and Addiction Program. So a lot of strengths, a few weaknesses. The big one, of course, is it's retrospective. I would love a randomized controlled trial comparing methadone and buprenorphine. Um, and the reason it's relevant is that those who chose methadone may have been different at baseline than those who chose buprenorphine. And they tried to control by all these different things, but there still could be some unmeasured confounders. In Canada, the difference between the two groups will be probably less stark than it would be in the US just because of the similar regulations of the two medications. However, even though they're similar, they're not exactly the same. So the Canadian guidelines for prescribing and dispensing buprenorphine are a little different from methadone. So a little bit of difference there. Um, and they're very different, of course, from the US. So it reduces relevance a little bit in our setting, even though it increases validity overall. And in the end, this isn't really their fault, but mortality was pretty low. So the mortality comparison estimates were kind of imprecise because they had low mortality, which is, good for them, but not quite so good for the study. So, John, did you think it was a valid trial?
Yeah, I mean, it seems like a very interesting question. I think that I know they always try to kind of adjust these kind of trials to see, like, especially these retrospective studies about, like, the two groups being similar. There's just always like an X factor as to like why one patient gravitates towards one medication or the other. And I feel like that's like that's where like the RCT would be great at some point because I think that's like the true measure of like which ones outperforms which.
Okay. Prediction. Are we ever going to have a randomized controlled trial comparing buprenorphine to methadone for opioid use disorder? Placebo controlled, randomized, double blind.
I read on RCT recently about comparing atorvastatin to rosuvastatin,
Really?
showing rosuvastatin outperformed atorvastatin. I'm like, where's that getting funded from? From the $4 Walmart drug list? I'm like, I don't know, maybe.
That's good to hear because rosuvastatin is my favorite statin. So I'm glad to hear it do better than Atorva.
I switched it up.
Anyway, back to addiction medicine. Let's talk about the results. So this paper had a lot of data in it, and reading it all out loud will probably just make everyone like fall asleep as they're driving to work. So I'm going to just share some of the most relevant findings. I tried to distill the data into a table that I made for myself and then I made for our live journal club. And I'll share that on our Facebook group and other social media. So if you want to look at some of the data in a table that I made, or you can look at the paper itself. But bottom line, to quote the authors, for patients who were taking medications for the first time for opioid use disorder, quote, the risk of treatment discontinuation was higher among recipients of buprenorphine and naloxone compared with methadone. So 88.8% discontinuation buprenorphine, 81.5% discontinuation with methadone at 24 months, 2 years. The adjusted hazard ratio is 1.58. The risk of mortality was low and not statistically different in either form of treatment. So 0.08% versus 0.13% buprenorphine versus methadone with an adjusted hazard ratio of 0.57. So people stayed in treatment longer on methadone, or rather, they were more likely to stay in treatment for 2 years on methadone than on buprenorphine. In people who started the medicine not for the very first time, but just after a gap of 30 days or more, they called them the prevalent new users. The risk of treatment discontinuation was 91% among people who received buprenorphine and 85.7% among people who received methadone. So again, same result. Hazard ratio is 1.44. And again, mortality was low. 3% in the buprenorphine group and 2.5% in the methadone group with a hazard ratio of 1.2. And remember, these are people who've been in treatment a few times. So maybe people who have more severe opioid use disorder had a higher mortality. These primary findings were supported by all the sensitivity analyses, looking specifically at young people, people with chronic pain, people with mental disorders, people with high or low rates of fentanyl in their area, different times, before and after the introduction of fentanyl, and different discontinuation rules, medication formulary changes, dose threshold changes. Basically, those findings remained the same in all these different scenarios. They also were consistent with a per protocol analysis, which included only patients who actually got the medication according to standard dosing guidelines. So people who stuck with the program, got all the meds, they also had better treatment retention with methadone. The mortality comparison, like I said, is uncertain because the low mortality, the confidence intervals in the methadone group and the buprenorphine naloxone group crossed each other. So you really can't say one was better than the other. But bottom line, methadone was associated with less treatment discontinuation than buprenorphine. So, John, what did you think of those results? Was that surprising at all to you?
I don't think that was particularly surprising. I think that we kind of makes a lot of sense, right, for the medication. It's kind of interesting how low the mortality rates were with this, right? I feel like that's kind of hard to give that much of a comparison. And I think that, like, the maybe I'm just drinking like the haterade a bit about methadone sometimes, but I feel like a lot of these outcomes for methadone are like HIV acquisition, hepatitis C, like retention to treatment. Like, they don't seem sometimes the most patient centric. I feel like, I would love to see like a functional outcome here too. Like, how people live their life. Do they feel like they're like, meeting the things in their life they want to do? Are they holding a job, good relationships with family? I like those outcomes in the trial. I know that's not what we're looking at, but
Right. Right. Life satisfaction, function. I mean, I just think like there is an association or a association in my mind of methadone with really being kind of dysfunctional and destitute, but I just think again, it's so hard to access that people kind of take it as a last resort. So people who are really sick, who are much sicker, end up in methadone treatment programs. And I do have some patients who are pretty highly functional while receiving methadone. Um,
Mhm.
but it's pretty limiting to your life, you know? It's
Well,
hard
especially
to
like
yeah.
the daily, like if you have early daily dosing, although it seems like I don't quite understand how the take homes work quite yet because I feel like I have patients now with like take homes very quickly for large amounts at some programs. It seems like, they're very early in recovery, already getting weak take homes. So I'm
Mhm.
not sure if that, like, if there was a standard process. I should probably know more about that at some point. Maybe I'll go down to our local methadone clinic and
Yeah.
shadow for a day.
Well, hey, I'm just about to send some med students there, so if you wanna be put on the roster, let me know. Like, you
Yeah.
could pretend to be a 3rd year.
This table has a lot of colors too. I feel like we should probably put like an epilepsy warning to very bright and colorful that you put
Right.
together.
Turn way down the, brightness of your screen before you look at my table. I was trying to color code it because there was so much data, it was hard to understand otherwise.
It's great. It's great. Just lots of colors. I missed this part of the live journal club.
Oh, well, now you can re-experience it. So, will these results help me in patient care? So, I personally cannot prescribe methadone for opioid use disorder, although stupidly, I can prescribe it for everything else. I could prescribe it for like GERD if I wanted to, but can't prescribe it to treat opioid use disorder because I don't work at an opioid treatment center. However, this paper and some other more recent data, as well as the devastation from the opioid overdose crisis, has led to some initiatives to promote methadone as a more viable treatment, especially in the US. Um, interestingly enough, prior to the publication of this paper, Canadian guidelines recommended buprenorphine as first line treatment for opioid use disorder. And then after this paper came out, they revised their guidelines and said that both could be considered first line treatment options based on patient preference. So that was a change. And then ASAM, the American Society of Addiction Medicine, is also promoting a bill called the Modernizing Opioid Treatment Access Act, which would expand access to methadone. Basically, as well as getting it in a specialized methadone clinic, physicians who are board certified in addiction medicine, like you and me, or addiction psychiatry could also prescribe methadone for treatment of opioid use disorder. And patients could get a dose at the pharmacy, so the doctor wouldn't have to be the dispenser also. Um, it would be kind of a modest change. You would still be have to follow the federally mandated kind of dosing and take home guidelines. But currently in the US, methadone is available in 49% of census tracts. Suburban and rural tracts is even worse. It's 34% in suburban tracts, and only 10% of rural tracts in the US have access to methadone. This act would expand availability to an additional 18% of suburban and 15% of rural census tracts because that's where the addiction medicine specialists are. Um, if you looked at a third scenario, a theoretical scenario where any doctor could prescribe methadone or any prescriber could prescribe methadone for opioid use disorder, that would expand access to about 86% of total census tracts, including 87% of suburban tracts and 68% of rural tracts. So I don't know if we're ready to open up methadone yet to all prescribers, um, even though all prescribers with DEA can actually prescribe methadone. We just can't prescribe it for the one thing it really works for, which is opioid use disorder. So, John, if you could prescribe methadone for the treatment of opioid use disorder, uh, well, I won't say would you do it. If all docs could prescribe methadone for the treatment of opioid use disorder, how do you think that would work out? Think it would go well, or do you think we wouldn't be able to do it correctly?
I think there probably needs to be some regulation. I think that the people that have expertise in it would be one thing, because it's a little different. Like, and here's why I think we should expand access first of all. So, like, I think it's a good idea to kind of have more places to prescribe this outside of an OTP. But like the data from like, the pain management guidelines, basically they make a statement about methadone for pain management that like it should not be used by non-specialists in pain management, right? That there's higher risk of overdose. It's an outlier of the opioids. And that kind of like it's a high association with overdose deaths when used by untrained operators, right? So I think
Right.
if you kind of deregulated methadone and you have someone without training in it, I think you could do some harm. I don't know. Or I could see this sort of like buprenorphine, and not that it's as big of an issue, but I do see people coming from these offices with these really kind of weird um, clinical indications for buprenorphine. Like I had someone the other day that their last doctor gave them because they're alcoholic. I'm like, well, where did that come from, right?
Right. Well, right, and methadone is much riskier than buprenorphine. I think that's the big problem. It's like it's not that people might prescribe it for the wrong thing, even though they might. It's that you can do some harm with it in a way that's harder with buprenorphine. That's what I worry about.
I think there needs to be some quality control, right? So board registry kind of waiver. There needs to be something that people that are just free prescribing this, that you're not going to have the doctor that's kind of like the lone wolf doing some harm. I mean, we were just talking before this podcast, right? It takes, we all know in each area who the overprescribers are, right? It's one or two docs that kind of totally feed this population unnecessarily, or they make a problem that didn't exist. Um, it doesn't take many.
Right, exactly. Right, they cause a problem, and then they disappear and everyone else has to help the patients fix the problem that they caused in the first place. On that note, thank you, addiction medicine doctors, for helping everybody else.
All right, so we have a little bit of talk back. We had a really nice comment from Katie Hill, an epidemiologist at Yale, and one of the authors of a paper reviewed on episode 50 of Kratom Journal Club. Her paper was about the prevalence of kratom use disorder. For those of you who listened to the episode number 50, she said, "Thank you kindly for reviewing our article and those of my wonderful collaborators. I found this podcast to be a great reflection on the current state of kratom research landscape as it relates to addiction medicine. I appreciate the comparison to Bupe and descriptions of kratom use disorder by DSM criteria. A lot of these thoughts y'all had were so similar to what we would love to put in a paper, but can't always publish in peer-reviewed literature. Really great work." I really, it's it's great. We appreciate the positive comment and we love the article. So it's great. I
Yeah.
think the kratom little subgroup was great for us because I feel like this was a muscle we don't often flex, right? I feel like it's something
Mhm.
we haven't covered. Always had to do a little bit of a deep dive to get some information about the disorder, the criteria, the patients. So it was actually kind of a nice additional tool in my arsenal, our little mini lecture series.
Well, and Katie said, a lot of the thoughts, it's so new and it's so evolving, you can't really look to the peer-reviewed literature for the information and these thoughts. A lot of it's not in there yet, and or it's too, I don't know, unfocused, unformed, hard to grasp, that it doesn't quite meet criteria for a big peer-reviewed paper, but it's still interesting and we still want to talk about it.
Yeah. Well, thanks for that. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in future episodes, send us your comments on social media, email, or join us on Facebook. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno. CME support from My Care is produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.